Hello, everyone. It's Melissa from Gilda's Club, Grand Rapids. So glad to be together on our virtual platform. I hope that we're finding you well and safe and really enjoying this incredible Michigan fall. Such a beautiful time of year. I hope you're getting outside and spending some time with people you love. We And if you're watching today and you'd like to let us know that you're watching, we love that. So please just either comment or like this post. If you find this post interesting and helpful, we'd love it if you share it with anyone you would like to. And if you're new to a cancer or grief journey and you'd like to know more about our free support program, please give us a call at 453-8300 or look on our website at gildasclubgr.org. So today we have a special guest with us because this month is one of the months that is a blood cancer awareness month. And so our special guest is Dr. Brett Brinker, who is a blood cancer specialist at the Cancer and Hematology Centers of West Michigan. Welcome, Dr. Brinker. Great to have you.
It's really great to be here. It's a privilege to be here. So thank you. I love working with Gilda's Club.
Yeah. Oh, well, we're so grateful to have people like you in our community that are resources for our community members and also are willing to do things like this when you don't even know what you're about to do.
I like it though. I think it's fun that way. So
yeah,
happy to
that's
help
great.
out.
Great. So obviously our topic today is going to be blood cancer. We have some questions that we have fielded from our members who have blood cancer and also from our general population, anyone who sent in a question for us. And so we'll just get started. Sound good?
Sounds good. I like it.
All right. So why don't you start with what is blood cancer?
Sure. Well, it's a very broad topic, but blood cancer, it's a whole host of diseases. This can sound silly, but that affect the blood system. And just briefly, to understand the blood system, think about the bone marrow. That's where you make all of your blood. And the blood is really composed of three different types of blood cells. There's the white blood cells, that's what fights infection for us. There's the red blood cell, that's what carries oxygen around our body. And then the platelets, that's what helps our blood clot. When you're talking about blood cancers, you're really talking about cancers of the white blood cells. These cancers might affect the red blood cells and the platelets, but you're talking about white blood cell cancers. It's a little easier to understand, say, breast cancer. It's a mass in the breast, or a colon cancer, a tumor of colon cells in the colon. But a blood cancer is generally a cancer of white blood cells. Now, what is a cancer? A cancer is a cloned group of cells. We're all humans, but thank goodness we look different. Well, blood cells are supposed to look different too. But if you've got a cloned group of white blood cells that are somehow evading the normal life, or birth, life, and death, living too long, reproducing too quickly, that's a blood cancer. Now, if those cancerous blood cells are mostly in the bloodstream, we generally call that leukemia. If most of those cancerous white blood cells are in the lymph nodes, we tend to call that lymphoma. So that's how you start getting terms like acute leukemias or non-Hodgkin's lymphoma. If something's really aggressive in a blood cancer, like in a leukemia, we'll call that an acute leukemia, as opposed to a slow-moving leukemia, we call that a chronic leukemia. In the world of lymphoma, we'll say a high-grade or aggressive lymphoma, or a low-grade or slow-moving lymphoma. The one variation on the theme is something called multiple myeloma, which is neither really in the bloodstream or the lymph nodes, it's truly in the bone marrow. And that's a cancer of a different type of white blood cell in the bone marrow. I could get more specific about all the different types of white blood cells, but in general, leukemia is bloodstreams, in the lymph nodes, lymphoma, and the bone marrow myeloma, and you're talking about cancers of white blood cells.
Okay.
How about that for a long answer? You could go on and on and on. You can have a whole 30-minute topic about just that. So.
Sure. And that makes a lot of sense. And I'm thinking, well, so many thoughts, but so the difference between like bone cancer is that the bone cancer is in the actual bone, where the blood cancer is in the marrow. Is that correct?
Oh, you nailed it. Yeah, actually, it's a common thing. People will come to me and say, I've had bone cancer, and they think they're referring to myeloma, but officially, myeloma, the whole problem's in the bone marrow. That's where the cancerous cells are. They have
Sure.
tremendous effects on the bone, the bones itself, but it's a bone marrow cancer. Sarcoma is the word that is usually referred to a true bone cancer. Certainly, solid tumors like breast cancer can travel to the bones, and that would be called metastatic disease. But a true bone cancer of the bone, sarcoma. Bone marrow of white cells oftentimes is multiple myeloma.
Okay. Oh, well, look at there. I did not know that. So I'm really glad to know that. What is the most common type of a blood cancer?
Well, if you put them all together, non-Hodgkin's lymphoma is sort of the greatest group, or the largest group. About 75,000 patients a year will be diagnosed with non-Hodgkin's lymphoma in America. But if you picked out just the one specific blood cancer that's the most common, that's called chronic lymphocytic leukemia, or CLL. And it's not that that one is overdiagnosed and it's just running rampant, but what's interesting about CLL is that it's a cancer, it's a leukemia you live with. So prognosis is measured in years and decades. So there's a lot of people living with CLL. So each year there's, I don't know, 20,000 new patients of CLL a year, but because so many people live with them, we use the word prevalence. It is the most prevalent blood cancer because so many people live with it for so long. So the short
I
answer to
see.
your question would be CLL, chronic lymphocytic leukemia.
Okay. So how would someone like, what are the signs and symptoms? What would bring them to the doctor? What are things people should look for?
Sure.
Yeah.
So, so it's such a wide range because you can have a really slow-moving chronic lymphocytic leukemia, and you could have had it years and you didn't even know about it until you showed up at your doctor's office and a simple blood test was ordered. As opposed to really aggressive lymphomas that patients go from I'm feeling good to feeling sick, fevers, drenching night sweats, losing weight just over a couple of weeks. But in general, the symptoms, well, let's put it this way, like chronic slow-moving leukemia is usually picked up by a primary care physician. So simple routine blood work once a year that notes an elevated white blood cell. The patient may have no symptoms, but the white cells are elevated, which is why one of the things to remember today is when you see your primary doctor, please get your blood checked once a year. It astounds me that patients will go see a primary doctor and the primary doctor doesn't order just routine blood work, a simple complete blood count. So anyway, so chronic slow-moving leukemias are often picked up with a simple blood count through a primary care doctor. But in general, symptoms related to blood cancers would be things like, I would put the words unexplained and persistent in front of these symptoms. So unexplained and persistent fatigue, unexplained and persistent weight loss, fevers. You don't have any signs of infection, but you're developing fevers. The sign of advanced blood cancer are night sweats. And night sweats are not to be confused with a menopausal hot flash, where you want to kick off the covers and you feel warm and you may be perspiring a little bit. I always refer to a night sweat as sort of a disgusting, drenching sweat, oftentimes at nighttime, that you're truly changing your pajamas, your pillowcases, and your sheets.
Okay.
If I could pick one symptom, and this is always a scary one to say, it's just, progressive worsening fatigue over a short amount of time. Because I talk with patients, I'm not 18 years old anymore. So over my lifetime from age 18, there's sort of the slow burn is where I don't quite have the stamina and the energy I used to have. But I am the man I was 6 months ago. I'm no different in terms of my energy level. So when you're trying to figure out whether the fatigue you're having is something that could be more ominous, it's progressive fatigue over a short time span, say 3 months, where you used to be able to do a lot, now you're doing less and less, now you can't get off the sofa. Those are things you would want to go to your primary care doctor about.
Okay, that's I'm glad that you put a time frame on that, because
Sure.
sometimes, a short period of time could mean 2 weeks, but you know, I love that. Am I the same person I was 6 months ago? It's such a great way to sort of self-evaluate about your current moment.
Sure. I mean, these are questions I bring to myself, right? I mean, I have bad days. I'm tired at the end of the day. Am I
Yeah.
okay or am I not okay? Well, that's the kind of my rule of thumb. I usually use a 3 month window. Am I still the same person I was on average that I was 3 months ago?
Oh, oh, that's great. Okay. Um, there's somebody asked a question. I'm just going to read it. Talk about how there's usually no option for surgery or there's a cutting out of
Oh, yeah,
cancer. So I guess this is about what is the most typical type of treatment. And then
sure.
we probably want to get more specific about that question.
Yeah,
So
yeah, that's a great. I can't wait to talk about that. There's some really
yeah,
exciting things going on in treatment these days.
okay.
Anyway, as medical oncologists, we say blood cancer is generally not a surgeon's disease, meaning they might help with an excisional biopsy of a lymph node, where they pull a lymph node out and we're able to look under the microscope and make a diagnosis. But you're generally not curing a blood cancer. And why is that? Because it's a blood cancer, meaning the blood is everywhere. So oftentimes it's more advanced than what's met on a CT scan or what's palpable on a physical exam. So it's generally a little more involved systemically because white blood cells are more systemically around the body. I guess if I'm saying that correctly. Again, as
Mhm.
opposed to say a breast cancer or a colon cancer when it starts out in those defined
Localized.
organs. Yeah.
Hmm.
So surgeons usually make helping us with a diagnosis. But the treatment is, again, it's a liquid cancer. It's treated with liquid remedies. So traditional chemotherapy and some of the newer immunotherapies where we harness the immune system to help fight the lymphoma, or what we call targeted therapies, where we find, thank goodness for research, where researchers find specific weaknesses in the cancer cell. I always say like the Achilles heel or the weakness in the cancer cell, and then through more research, we find drugs that go after that specific weakness and turn on that signal or turn off that signal, and that helps the cell die. But
Hmm.
right, it's not a surgeon's disease. Now we will use radiation in some situations, in some non-Hodgkin's lymphoma, if a lymph node is truly the only area that we can find the lymphoma by our additional imaging, and I can tell you about tests here shortly. But if it's truly confined to one area, sometimes we will try to radiate one specific area and hope that, of course, the lymphoma never comes back after that. But
Okay.
a surgeon, no, generally not a surgery. They're a great help, but they're not a treatment remedy for these types of blood cancers.
Sure. Okay. And so I guess we kind of jumped that piece of what is the diagnostic test that they would do, blood test
Sure,
you said, and then that would sort of alert you to maybe be referred to you um,
sure.
or someone like you, and then what would happen?
Yeah. So it depends on the type of blood cancer, but there's usually several modalities or modes of testing that we would do to figure out whether someone has a blood cancer. So one would be a complete blood count. So we're looking under the microscope and to see if there's any a cloned group or abnormal group of white blood cells. I'm going to throw some words out there. You can remember them or not remember them, but these are the tests that if you ever diagnosed with blood cancer, these are the buzzwords you're going to hear when you're talking with your doctor. There's a test called flow cytometry. Flow cytometry is a test on the white blood cells that picks out the proteins, which is the equivalent of a fingerprint on the outside of the white blood cells,
Hmm.
and tries to determine if it's that same protein fingerprint over and over and over again. So you're
Ah,
demonstrating clonality. So leukemia is picked up by a test called flow cytometry.
yeah.
When we're thinking about lymphoma, we're thinking more about CT scans, or better yet, the PET scan.
Mhm.
PET. It's called the CT PET scan. Most of us are familiar with CAT scans. They're an image of the inside of our body, our lungs, our liver, our heart, and it shows us whether things are there or not, big or small. And it will show, for a patient with lymphoma, enlarged lymph nodes. Lymph nodes are normally about the size of a quarter of an inch, but it's not unusual for someone with lymphoma to have 1 inch, 2 inch, 3 inch sized lymph nodes. But the way we pick out whether those lymph nodes are live or active with lymphoma, it's called a PET scan. PET scan is a sugar test. So it's a CAT scan, but they give you a special dye, and that dye is actually a slurry of sugar, and that sugar is coated with a special tracer. Lymphoma cells, being the greedy little buggers that they are, they suck up that sugar, and it lights up literally on the CAT scan where the lymphoma is. So it provides greater definition, the PET scan, of where the lymphoma is. It's extremely important because that's like the pre-picture. Okay, we see where the lymphoma is on a PET scan. Then we do our treatment for several months, and then we repeat our PET scan. A lymph node that was lighting up, we don't want to see lighting up anymore. So it's a really
Yes.
definitive way to figure out when someone asks me, well, doc, did you get it all? Well, that's where a PET scan, the pre and post-treatment PET scan are very helpful.
Oh, that's
One of the other
great.
major tests I would, when you're talking about blood cancers, you can't get too far without talking about a bone marrow biopsy, which people live in fear of, a bone marrow biopsy. Particularly for multiple myeloma, we have to get into the bone marrow, which is a needle that we do. It goes into the back of the hip bone, goes through the bone and into the middle mushy marrow. And that's how we're able to figure out whether someone has myeloma. Also, we use it a lot for acute leukemia and sometimes for lymphoma as well. I will say the bone marrow biopsy sounds horrific and medieval, but actually under the right people who do lots of them and proper anesthetic, it actually is a very quick procedure. You will feel pressure. You'll feel the bee sting of the numbing medicine for 3 seconds or so, but it isn't something to live in fear of. Again, in the right hands, like our group, we do lots of bone marrow biopsies and go out of our way to make sure patients are comfortable for that type of test.
Yeah.
Unfortunately, when you tell someone they're going to get a bone marrow biopsy, usually it's a friend of a friend, or they go online, they hear horrific stories about bone marrow biopsies. And I would just like to say, in the right hands, it is a reasonable, fairly quick procedure, and not as horrific as the world has led on to believe
Sure.
about a bone
Yeah.
marrow biopsy. So
Okay.
um,
Oh,
anyway,
great.
blood work, PET scans, bone marrow biopsy are the main things that we're looking at
Okay.
to look at different types of blood cancers.
Okay, great. And it sounds like that also is just really helpful within the treatment realm, also the pre and post
Sure,
and that kind of thing. So
sure.
then, and we talked a little bit about treatment already, and then you loved that question about cutting it
Sure.
out. And so you want to talk about that now?
Sure. So, like I said, the treatments are chemotherapies or drugs to treat. So again, in the rare situation, we'll do radiation. We're not doing surgery, but you're talking about different systemic treatments.
Mhm.
So if you broke it down, and I'll break it down into 4 different types of treatments that we use. There's chemotherapy, which I'll comment on. Then there is immunotherapy. Then there's targeted therapy. And somewhat related to immune therapy is the bone marrow transplants, which I'll comment a little bit about in that. So first of all, chemotherapy. In general, chemotherapy is what you think about when someone says chemotherapy. There are drugs that we'll use for certain types, not all, but certain types of lymphomas that use traditional, we use the word cytotoxic or cell-killing chemotherapy.
Mhm.
They're actually extremely effective, but they are, of course, the ones that cause the side effects that the people worry about are stereotypically losing the hair, potential for nausea, potential for diarrhea, fatigue. So we do use those because they're quite effective. However, we have a lot of better medications to help support patients through that. And usually when we're using that type of chemotherapy, it's because we know the payoff long term will be good in terms of remission rates and even cure rates for some blood cancers.
Sure.
So there is traditional chemotherapy. The newer things we're looking at are targeted therapy. So targeted therapy, as I said, these are often pills, which makes life a lot more convenient for patients. But these are where certain proteins or certain parts of the cancer cells have weak points. The pills are designed to go after those weak points and switch off the cancer cells. And
Hmm.
so those are generally well tolerated. It is, the oral drugs, the side effects are usually much more mild, maybe mild fatigue, sometimes a skin rash, sometimes low blood counts, but doesn't carry that heavy, life-altering stigma of intense chemotherapy that sometimes we have to use.
Sure.
One of the biggest toxicity of those things is financial toxicity. So those drugs are extremely expensive, tens of thousands, $10,000, $15,000 a month type therapy. So we
Wow.
rely heavily on insurance companies to help with that. There are a lot of great programs in Grand Rapids, philanthropy groups that help with that and grants. I will put a
Mhm.
polite plug in for the Leukemia and Lymphoma Society, who does a lot of work as well with philanthropy to help and grant money for those expensive drugs. But they're pretty amazing. And in fact, in many different types of cancers, particularly chronic lymphocytic leukemia, the pills are more effective than the chemotherapy now, so which is great
Hmm.
news for our patients.
Yeah.
Next topic, next treatment I would consider is immune therapy. This is one of my favorites because really all the drugs, the chemotherapy, the targeted drugs, they're all about killing the bad guys, right? If you're going to say the cancer cells, the bad guys, those drugs kill the bad guys. But what about helping the good guys? And what are the good guys? That's your immune system. So the immune therapies go about trying to help your immune system be more effective at killing cancer cells, something the immune system is supposed to be doing in the first place before cancer was ever diagnosed. But finding out more and more, the immune system doesn't just kill infections, it actually is very much a part of killing cancer cells. So those are the immune therapies. You might have heard of drugs like Rituxan before. Rituxan is the
Yeah.
classic one that binds onto lymphoma cells and gets your own immune system to kill the lymphoma. Well, there's a whole host of new drugs that immune therapies. I could list a whole bunch that to go through, but they generally augment or help pill-based therapy, the targeted therapy, or chemotherapy. One of the biggest ones is called CAR T cell therapy. I won't go into it too much, but this is a true where we collect someone's T cells. What are T cells? That's the police force. So the T
Yeah.
cells are the cells that help control all the other cells that have gone bad. And so one way to improve upon T cells is literally to collect someone's T cells through their bloodstream, and they get sent off, genetically engineered, and then put back into the patient, where when they go back in the patient, they are ravenous for killing blood cancer cells. So it's a really neat modality that's just now coming into the limelight. The last treatment I'll talk about was what we use for a lot of acute leukemias and myeloma, as well as the bone marrow transplant,
Yeah.
which is really a misnomer these days. We really don't transfer bone marrow. People think we're going to pull bone marrow out of one person and put it to another. Actually, what we're after is stem cells. Stem cells are the cells that give rise to your white blood cells, red blood cells, and platelets. So an example of multiple myeloma, one way to kill off myeloma cells is to give a very high dose of chemotherapy. The problem is that it kills stem cells. So we'll pull someone's stem cells out, we'll collect their stem cells, take them out of the body, put them in a freezer, give a high dose of chemotherapy, then put those same stem cells back in a person. It's a very effective way for long-term control of myeloma. Most of what people think about when they think about stem cells, they think about a donor. That's a different type of transplant. That's where we're going to someone, either a brother or a sister, a family member, or just a good Samaritan out there in the world. And by the way, in the world of blood cancer, there are so many great Samaritans out there in the world. So, who are willing to donate stem cells. So this is a situation where we will give someone chemotherapy to really wipe out their own marrow and kill their stem cells just in time to take a donor's stem cells and put them into a patient. That serves two purposes. Those new stem cells, one, don't give rise to cancer cells anymore. Number two, new immune system. New immune system that doesn't like the old you, doesn't like those old leukemia or lymphoma cells. So it's another way to help control a leukemia or lymphoma long term.
Sure.
A lot of baggage that can go with that. That's not an easy endeavor, but it is another effective way. And we're getting better at doing stem cell transplants, cleaner stem cell transplants, less side effects. So we certainly have a way to go with that as well.
Oh, that's great. It's like repopulating their stem cells. Yeah. And
it's truly a new immune system is what it is.
Yeah. Oh, wow. It's amazing.
And I could go another whole, I could pick any one of those modalities and make that a 2-hour discussion about targeted cells, chemotherapy. You could go on. But I think the point that we should get home to the listeners out there is that there are new drugs and new treatment modalities that are coming out with a rate that we haven't seen before. So I see a lot of times when I'm treating a patient with a chronic blood cancer, while I'm treating them, their prognosis is getting better because new drugs keep coming out. Which is why don't always hang your hat on what the computer says how long you're supposed to live. People love to do that. Get a diagnosis, go right to the computer, they blow off everything, go right to the survival estimates. And they really, I guess I would do the same thing, so they're not to be blamed for doing that. But I also would like to caution them not to hang their hat on that. Because when you're looking at survival estimates, you're looking at 5-year retrospective, looking backwards. In those numbers are people who are 90 years old and all sorts of people who may not fit the fact that you're 50 years old. And so those people are not all like you. But they don't take into account the treatments that are right now, but most importantly, they don't take into account the treatments that are coming. So that's why I caution my patients every time I'm meeting a new patient. I'm saying, please don't get hung up on survival estimates, because more often than not, we're blowing them out of the water. So they're doing better and living longer.
Great. We have a question for you. What are
Mhm.
the side effects for CART, C-A-R-T?
Yeah, CAR T cells. It's a great question.
Yeah.
So CAR T cells, the way it works, again, we collect someone's T cells, we send them off. It takes about 4 weeks to get those T cells, engineered, genetically engineered, and then put back into the patient. Patient is usually been placed in the hospital when those CAR T cells go in. So the side effects are more sort of the shock to the immune system. When those new
Mhm.
T cells come in there and they go and attack the lymphoma cells, to me, the way I think about it, it's the equivalent of kicking a beehive, right? You want to kill the beehive, you give it a big kick, and all of a sudden the bees go, nuts. Well, the same thing with the immune system. So the immune system goes into a hyper-inflammatory state. And so
Mm.
that can cause some low-grade fevers, sometimes a little skin rash, but sometimes, which is why we do this in the hospital, it can have a infection-like appearance, something we call sepsis, where like the blood pressure drops off, and the patient can be quite ill for a few days. What's interesting, it always seems to happen between day 4 and day 8. So actually, we're becoming so familiar with that, we have medications that reverse that, and we know it's a defined amount of time when that sort of inflammatory reaction is. Now, a
Mm.
few days later, there's potential for neurotoxicity. Neuro meaning nerve system and brain. So it's a similar inflammatory issue, but it affects more of the nerves. So some patient can get a little headache, maybe a little slow thinking, um, confused. But in the worst case scenario, I don't want to scare everyone, but in the worst case scenario would be like a temporary coma. I mean,
Mm.
it's significant business. Is something to watch out for. Now, that is definitely an exception in the minority of patients, and that too is improving as we learn how to work with the CAR T cells. But you ask a question, if there are side effects. Those are the two biggie ones. The immune reaction that happens a few days after, then a few days later, the potential for neurotoxicity.
Okay.
There's also the risk for infection. You are manipulating the immune system. So patients are on a lot of immune type medications, antibiotics and antimicrobials to prevent infection. And the immune system is a bit suppressed for a long length of time. So those are things we have to watch for long-term infections. Usually shingles is something we have to watch for,
Ah,
which is
sure.
chickenpox showing up in your nerves. So,
Yeah. Yeah. And what
eh,
what is a long period of time? What's a long length of time?
for like side effects afterwards. So is
Yeah.
that what you're
You were
asking?
saying,
Yeah.
and for
So
the
I would,
antibiotics and antifungal.
yeah,
Yeah.
some of the immune suppression can go on for a couple of years, but they're not like a ticking time bomb. It's just that, for infection, it just means that their immune system is a little bit low. Probably the more worrisome period is a 3 to 6 month period afterwards.
Okay.
But some patients might have chronically no immune system, but they're still going about their life and going about their business. What's nice about CAR T cell is you get that treatment over with, and then you're off therapy, as opposed to patients who are on chronic pill-based therapy or chronic chemotherapy. So the CAR T, you sort of get in, get it done, and then hopefully you're put into remission and have this nice long period where you're on zero, really essentially no treatment other than surveillance with the doctor, looking for any signs of recurrence, and then a couple of pill-based therapies to help reduce the risk for infection.
How many times can you do CART?
Right now, about once. Yeah, so
Okay.
generally it's done one and done. That doesn't mean there aren't clinical trials looking at repeating. For example, if someone had a nice 3-year remission and then the lymphoma came back, because generally we use it for lymphoma. If the lymphoma came back, there are trials looking at a second time around. But as it is right now, it's only approved by the FDA for one time. But
Okay.
again, things change. But right now, it's pretty much just one time. It's a
One
very
time.
expensive thing to do. So insurance companies and payers will pay particular attention to what the FDA has to say about it, because it is not an inexpensive thing to do.
Okay. All right. So another question is
Mhm.
it true that lymphoma can become immune to treatments eventually and never go back to?
So yeah, so the answer is refractory to treatment. So there can be the answer is, well, yes, very much so.
Mm.
Because there are some lymphomas that you can treat and can truly cure. You treat for 6 months of chemotherapy or immune therapy, it goes away and never comes back again. And that is wonderful, obviously wonderful for patients. On the flip side, there are patients who die from blood cancers. And so that's what that means. That means you've truly become refractory to all the treatments. So Right. So a lymphoma we can treat for a while, and the lymphoma cells learn how to navigate around a certain chemotherapy or immune therapy or a targeted drug. Whereas 5 or maybe 10 years ago, the bench was not deep. We didn't have any of the drugs to pull off and try to treat those patients if one or two treatments became failures. Now we say the bench is deep. We've got all these different drugs to keep pulling off. If one doesn't work, we try another one, or we try another one in a different combination. So
Sure.
some of these lymphomas, why they may be hard to cure, they become chronic illnesses with really long, drawn-out times of treatment, times of no treatment. But absolutely, that's the problem. The lymphomas of leukemias become resistant to our treatments, which is why we're cancer and hematology centers. We try to do lots of research in terms of working with different companies, trying new drugs, trying to advance the field for leukemias, lymphomas, and myelomas. So
Sure.
research it's a really neat time to be able to tell a patient, the bad news, I'm sorry the lymphoma's worse, but here's the good news. I've got something new, right?
Yeah.
And there's another one coming. So we keep trying to kick the can down the
Yeah.
road for the next drug to come out. So
Yeah.
it's
I
really an
noticed you
interesting
guys.
time.
I noticed you guys are involved with the consortium,
Yes, we are.
yeah, here in West Michigan, and that's great because
Yeah,
they're
yeah,
incredible.
sure. Yeah,
Yeah.
we do a lot. We like to do research working, with some of the new medications. So we have the Cancer Research Consortium, which is great. We do trials
Yeah.
at cancer and hematology centers. We also do what's called phase 1 studies, so what's called the START program. These are drugs that are just coming off out of the research, where out of the research bench, brand new drugs, new concepts. So we even have that available to our patients. It's a pretty
Mm.
neat time to be in Grand Rapids. Uh, with all the money, time, investment, personnel into healthcare, there's a lot of we have a lot of the treatments right here and novel treatments on the near horizon right here. So it's an exciting time to practice and to help patients in Grand Rapids.
Yeah. Oh, that's great. So I'm noticing we're kind of running out of time. And so I have a couple of questions I wanted to get to, maybe just a couple of words about it is what about B cell lymphoma and COVID? Um,
Oh, great
are
question. Yeah,
okay, yeah,
yeah. I'll try to be succinct so we can get through a few questions. So,
sure.
Leukemia and Lymphoma Society just came out with a trial examining how the vaccines do for our patients with blood cancers, not just lymphomas, but leukemias and myelomas as well. And what they found out that approximately 30% of patients, when you have a blood cancer, and particularly when you're on blood cancer with any type of treatment, 30% of the patients don't even get a good response or even any response to the vaccine. And the
Mm,
70% of the patients who do, they sort of have a blunted response compared to the average person in the street who gets a COVID vaccine.
mm,
So it is less. But we feel as blood cancer doctors, the vaccines still prevent the major catastrophes that can happen with COVID. And unfortunately, when you're talking about blood cancers, you're talking about cancers of the immune system. So
right.
therefore, COVID has really affected some of our patients, and they've become quite ill. And again, I don't want to sound scary, but we've lost a few patients to COVID.
Yeah.
Um, so the vaccines at least seem to prevent the worst things that can happen from COVID. But we are recommending, not just us in Grand Rapids, but nationally, blood cancer doctors are recommending the boosters for our patients with blood cancers. Whether Pfizer or Moderna. I guess we're learning a little bit more about the Johnson and Johnson, but
Hmm.
in general, we are recommending that booster because of the lack of response or the blunted response. And the next question is, well, all right, if I get that third booster, it's going to work great, right? Well, we don't know yet. That's the next trial that comes out. So once we get the boosters, then we examine those patients and see how well the booster helped. But at least as of right now, we go with the information that we've got, and we are recommending the booster for our patients with blood cancers. And you
Okay.
can't game it right. People say, like, well, I'm about to get chemo. Should I get the booster now or should I wait? When you're on treatment, just get the booster because there isn't a quite right, perfect time. Now, if you're off
Yeah.
treatment, anytime, go ahead and get the booster. Anyway, if
Okay.
you've not had any major allergic reactions or problems, we are recommending the booster.
Okay. And are you doing those COVID blood cancer trials here in Grand Rapids, or is that a national trial somewhere else?
That's a national trial. That we're not actually, we're not actually putting patients on that trial. Each centers
Okay.
around the country have their different things they're working on. That
Okay.
specifically in our office we're not working on, but we are
You
certainly
get the
paying
numbers.
attention
Sure.
to the paying attention to
Yeah.
the trials that are coming out.
Okay. How about the wait and see, watchful waiting piece? Um, you want to just speak to that a bit? Yeah.
Sure, sure. It's a scary concept, right? But
Yeah.
actually patients get used to it. Um, So this is for the low grade or slow moving lymphomas or classically chronic lymphocytic leukemia. Sure, we know you've got a cancer of the blood system, but it's not really causing any problems. The biggest problem is having to wait to see the doctor or to follow up. But the actual leukemia lymphoma isn't causing the patient problems other than the with understandable anxiety of knowing they have the problem. So oftentimes that can go on for years. I've had some patients where it's gone on for 20 or 30 years, and the patients are
Hmm.
outliving the blood cancer doctors. I mean, and they haven't really needed any treatment because for some reason that patient's immune system figured out how to control that blood cancer. So
Hmm.
they've never needed any types of side effects from drugs and treatments. So they've done well on a watch and wait basis.
Okay.
Sooner or later, most patients need treatment though, and then we will treat based on symptoms. I'm more tired. I've got a lymph node growing in my neck. I'm losing weight. So the art though is not to have a patient get sick from cancer. We don't want that to happen either. But if the blood cancer is starting to affect the patient, then the time to come in is the right time to come in and treat. And
Okay.
if a patient is absolutely just cannot live with the fact that they're getting a watch and wait, then we will treat them, but reluctantly so. Remember, this is not breast cancer or colon cancer. That would be crazy to sit and watch and wait one of those cancers. You would never do that.
Right.
But a blood cancer, low grade, slow moving blood cancer, you can watch if it's not causing the patient particular problems.
Okay. And so if a patient has really feel strongly they're having a reoccurrence, they might have some signs and symptoms, maybe a lymph node, and their doctor is not necessarily on board. Do you have any advice for that? Maybe how to get some activation with that?
Yeah,
I
get a new
love that
doctor
you
would be the
said that
first
you,
one. So
pardon?
get a new doctor. So, I mean,
Ah,
if you're following with the blood cancer doctor and your blood cancer doctor is ignoring blatant symptoms, which you just described, I would recommend you get a new doctor because
okay.
those are classics. That's the why you do the follow up.
Yes.
It's not that we do CAT scans every time we see you, but we're very low threshold for any sort of subtle sign of losing weight, fatigue. So the question you're asking is a good one, but I have to say it doesn't come up a whole lot because any decent blood cancer doctor or primary care doctor who knows you have a history of blood cancer should be on that right away. That should be fairly straightforward for a
Okay.
primary care physician if they know you've got a blood cancer, and certainly for the blood cancer doctor to be able to pick up on
Okay. Oh,
that. Usually
great.
it's not a hard sell to have a doctor listen to you when you have a history of blood cancer.
Oh, that's great. Great advice. Okay. I think really we hit, I think all of that, other than there was a question, is there an age group this typically hits more than
Mm.
others?
Yeah, because you're talking about such a broad, blood cancers is such a um, broad spectrum of patients. The answer is it can, to be honest, it can go from a toddler or a baby all the way up to an elderly patient in their 90s or so. But in general, there's classes like Hodgkin's lymphoma, which is a specific type of lymphoma that tends to affect younger teenagers, 20 somethings, 30 somethings. Acute leukemia, on average, again, these are averages, tends to affect an older patient in the 60s or 70s, also
Mm,
like chronic leukemia. Non-Hodgkin's lymphoma can run from 20s up in the 70s and 80s. The one blood cancer that's truly unique well, not truly unique, but most common in kids, that's acute lymphoblastic leukemia, or ALL. We generally see that in younger kids, even toddlers. Though as we live longer, the good news is we're living longer. We're also finding out as patients live longer, we're seeing a recurrence of ALL as patients get older as well. So that's a
interesting.
long answer to a question that it depends on the type of blood cancer. The point is to
Sure.
follow up with your primary doctor once a year, get your blood tech, to pay attention to symptoms, but But remember, persistent and unexplained. We all have good days and bad days. And it doesn't mean you've got a blood cancer because you're tired at the end of the day of work, or you've had
Right.
you're getting over a little viral illness that's set you back a couple of weeks.
Yeah. So I just want to remind our listeners that whole, am I the same person I was 3 months ago or 6 months ago? And I love that, and helping yourself judge, because you could even have a week where you're really tired.
Oh,
And
sure. Yeah.
right now everyone is a little bit tired of just dealing with everything we've been dealing with in the world.
Goodness,
And
you're
so,
right.
is it more persistent than that or different than that? And so,
Right.
yeah. So I
I
like
would say
that.
one thing about the stress. People, one of the questions I get asked, what causes cancer, and that's a whole other topic. But
Yeah.
one of the things that comes up, I can throw another tidbit out there, is stress. People always like, Doc, did stress cause my cancer? I'm having a bad time at work, and now I got lymphoma. So stress is a tough one to handle. We always talk about managing stress, exercise, eating right, whatever, wherever you find peace, whether it's through church or friends. But oftentimes in the press, they'll say a simple thing that this causes cancer, like stress causes cancer or sugar causes cancer. It's way more complex than that. And the reason why I put that out there is, if my doctor told me that stress causes cancer, what's the first thing I'm going to do? Get stressed, right? So it's going to make me even
Right.
more stressed. So I would caution people when they're looking for causes of why they or a loved one has cancer. It's more than just probably one thing, like they ate too much sugar or they're too much stress. There's a lot that goes into it, and a lot of it's genetics, and that's still a big field for blood cancers that we're still just now cracking some of the codes, that whether some families have an increased risk. Breast cancer is far more advanced in terms of figuring out,
Yeah.
this is called the BRCA1 and the BRCA2 gene, where we can see grandma, mom, and granddaughter get breast cancer. We're not that sophisticated yet in blood cancer. So that would be a great area of research that we're trying to look into to figure out whether there's a family increased risk for some blood cancers.
Yeah. Wow. Well, great information. Well, I'm going to put a cap on it now because we've gone over a little bit, and we really
Oh,
appreciate
sorry.
your extra time. No, it's not your fault. I think it was just really good conversation and important things, but I want to honor your time too. So I
Thank you.
just so appreciate you spending time with us, Dr. Brinker, and sharing your passion, obviously,
Right.
and your knowledge with us. Yeah.
Good.
So
Well, thank you again. The pleasure's all mine. I really love working with the Gilda's Club. You're such a great organization, and you're tremendous help to our patients. So thank you for all Gilda's Club do for our patients.
yeah,
So
well, it's
again,
truly
it's
our
it's a
honor.
pleasure to be here. Thank you.
Yeah, great. Thank you. All right, for all of you out there, if you have more questions for Dr. Brinker, you can send them to us, or you can look up the now I'm going to say that wrong, Cancer and Hematology Centers of West Michigan, and you could send them an email also, or call them up and talk with them on the phone. If you're new to a cancer and grief journey, and or you're supporting someone on a cancer journey and you'd like more information about our free support program, please give us a call. We'd love to connect you with our community, 453-8300, or give us a call or give us an email on our website, gildasclubgr.org. We are just tipping our toe back into going back in person. Yay! We've had a full virtual program for all of the COVID craziness. And so we're happy to start to see people in person. And we're still keeping that bit of virtual along with that for those people who maybe don't want to come back in person or can't, like you were talking about, Dr. Brinker. They have to be more careful. So
Good.
just look on our website, pay attention to our calendar, or give us a call. We'd love to talk with you about that. Other than that, I think that's all I have for today. Thank you again, Dr. Brinker, for being here. And yeah, be well.
Thank you very much. Thank you.
Yeah. All right. See you, everyone.